Bismillah ar-Rahman ar-Rahim. Today we'll be discussing Enchondroma, which is really a dilemma for the orthopedic oncologist and the general orthopedic population. So why is it a dilemma, and how do we treat them? By the end of this lecture, we're supposed to be able to answer the following question. What is an enchondroma and how common is it? How do they present? How do they look on X-ray and MRI? What are the different types of enchondroma and how do we differentiate between them? How do we treat an enchondroma? And at the end, I'll suggest an algorithm for management. So an enchondroma, it's also called a chondroma, accounts for about 25% of all benign bone tumors. Probably the percentage is higher because a lot of enchondroma may pass unnoticed and only discovered accidentally. There are no sex predilection. They mostly occur in the short bones of the hand and feet, but they could occur also in long bones. They could occur in the metaphyses, the aphyses, and possibly also the epiphyses of long bones, mostly in the femur and humerus, but could occur in any long bone. However, they never occur in bones of membranous ossification like the clavicle. A possible etiology of the enchondroma is migration of cartilage cells from the growth plate into the marrow. However, this is not a confirmed etiology. So what is an enchondroma? It's a benign intraosseous tumor made up of well-differentiated cartilage. How do they appear on X-ray? Actually, there are two patterns. Either they appear as purely osteolytic lesion, which is common in the hands and feet, or they appear as intramedullary popcorn calcifications, calcifications in the form of rings or arcs. And this is common in the metaphyses, the aphyses of long bones. This is how they look on the X-ray in the proximal phalanx, which is actually the most common site in the hand. And you can see it's a purely lytic lesion. Whereas in long bones, they usually appear as calcification in the medulla, what we call smoke up the chimney. And you can see here the calcification in the form of an arcs and rings. So how will the patient with an enchondroma present to the orthopedic surgeon? There are four scenarios. Either they appear accidentally while investigating a non-painful condition. And in the recent couple of years, a lot of patients who did X-rays for the chest to investigate COVID were diagnosed with enchondromas of the proximal humerus. The other scenario is accidental discovery while investigating a painful condition. Patient with osteoarthritis doing X-rays for her knees, and then she discovers that she has an enchondroma, or a patient with a rotator cuff disease doing an X-ray or an MRI for his shoulder, and he discovers that he has an enchondroma. And the third scenario is that the patient comes complaining of pain due to this enchondroma, or the patient presents for the first time with a pathological fracture, and this is common in the enchondromas of the hand. So these are the four scenarios that the patient could present with. We have to bear in mind that the incidental finding of enchondroma in MRI around the knee is around 3%, and around the shoulder in 2% of the MRIs. Stump et al., actually, he gathered all the MRI done for the around the knee, and he discovered that 3% of these MRIs showed incidental cartilage lesions. The same was done in a similar manner by Hong et al., and he discovered that 2% of the shoulder MRIs showed incidental cartilage lesions. So, the first scenario is the accidental discovery while investigating a non-painful condition. If you look at this X-ray, this patient came complaining of a knee trauma on the right side, And while she was doing an X-ray, they discovered an enchondroma on the contralateral side, which was not the painful limb. The other scenario is in this patient with an osteoarthritis of the knees, and while she was investigating her osteoarthritis, she discovered an enchondroma of the distal femur. This is a patient who had shoulder pain, and you can see from the MRI that she has rotator cuff supraspinatus tendinitis, and an enchondroma was discovered while she was investigating her shoulder pain. The third scenario is the patient coming complaining of knee pain due to an enchondroma of the distal femur. So here the source of pain is actually the enchondroma. Or the fourth scenario is a patient presenting with a pathological fracture, like this patient with an enchondroma of the proximal pharynx of the ring finger, and she presented for the first time with a pathological fracture. She didn't have any complaint prior to this fracture. So how do we manage these patients? Our aim in management is actually as follows. We have to know if this lesion is actually an enchondroma or something else. And the second thing is we have to know if the enchondroma is the cause of the pain or the pain is due to another pathology. And the third thing is, if this is an enchondroma, does it pose any future threat for the patient or not? By answering these three questions, we could plan our treatment. So how do we do this? How do we answer these questions? We have to take a proper history, and from the history, we know the different scenarios that happened. We have to stress whether, if it's a painful condition, about what incites the pain, what decreases the pain. Like, for example, a patient with a rotator cuff disease may have pain only on movement, but not at rest. Patients with osteoarthritis may have bilateral similar knee pain, and they have pain, patellofemoral pain, for example, with stairs, etc. Whereas if the pain is due to enchondroma, it is a constant pain, progressive pain. We have to examine the patient properly and know exactly where the point of tenderness is, because for a patient with an osteoarthritis, they'll have the pain at the joint line, whereas if she has a pain due to an enchondroma, she'll have the pain over the distal femur and not the joint line. We have to examine for wasting, we have to compare both sides, etc. So these are methods to identify whether the pain is due to the enchondroma or due to the other pathology. Of course, we have to evaluate the imaging studies. X-ray is very important. We actually diagnose enchondroma easier with an X-ray than an MRI and CT. So we have to order an X-ray if the patient is coming only with an MRI. And if she has an X-ray, we have to do as well an MRI or CT to evaluate the patient. There is no role for lab investigation to diagnose an enchondroma. We don't need to do any laboratory investigation, CBC, ESR, tumor markers for this condition. Even bone scintigraphy is not of that importance. We'll come to this later during the lecture and its role. But actually at this stage, we don't need to do any bone scintigraphy to diagnose an enchondroma. So by doing these things, we evaluate the patient. So how does the enchondroma look on X-ray? As we've mentioned, it looks like a popcorn calcification. Here we see an enchondroma of the proximal tibia. The MRI will show the following. In a T1 weighted image, the cartilage will appear of intermediate signal intensity, like we see in the bottom left side here. And in between the intermediate signal intensity, we'll find the bright signal intensity of the fat, of the marrow fat, in between the cartilage lesion. The dark signal intensity or the low signal intensity corresponds to the calcification that we see up here. In T2 weighted image and in the STIR, fat suppression, images, the cartilage, which was intermediate intensity in T1, will appear of a high signal intensity because of its high water content here. And the fat in between will appear dark, and the calcification will appear very dark. So this is how the cartilage lesion, the enchondroma, will appear on the MRI. We have to know that there is a big spectrum of cartilage tumors, and these are one of the tumor groups that actually the grade differs very much in the management. So we have the latent enchondroma, we have the active / cellular enchondroma, the chondrosarcoma grade half, or clump lesions like what we call the cartilage lesion of undetermined malignant potential. We have the chondrosarcoma low grade, grade 2, high grade, and the dedifferentiated chondrosarcomas. All these are the different spectrum of the cartilage tumors. If we take a closer look at these, what we actually need to know is to differentiate the types that differ in treatment. So for latent enchondroma, all what we need to do is follow up, whereas the second group of active enchondromas and chondrosarcoma grade half, the ACTs, the clump lesions, all these will be treated similarly with extended curettage. Whereas the higher grade chondrosarcomas will be treated with wide resection. The dedifferentiated chondrosarcoma will need wide resection plus possibly chemotherapy. So what we need to do to treat the patient with enchondroma is actually to differentiate between latent enchondromas which will be treated conservatively versus the ACTs and the low-grade chondrosarcomas, which are going to be treated with extended curettage. So this is a very important differentiation. And we also need to differentiate between this group of ACTs and low-grade chondrosarcomas versus the higher-grade chondrosarcomas, because the first group will be treated with extended curettage, whereas the higher-grade chondrosarcomas will be treated differently with a wide resection. So we need to differentiate between the group which we're going to treat them conservatively versus doing curettage, and between the group which we're going to do extended curettage versus wide resection. So how do we differentiate between these two groups, clinically and radiologically? So what are the MRI features that differentiate between the latent enchondromas and the atypical cartilage tumors, the ACTs? Actually, the main differentiating issue is the presence of industrial scalloping. We find that the cartilage is actually scalloping the inner aspect of the cortex. The heterogeneity and the size is actually a debatable issue. Many authors have mentioned that size more than 5 centimeters corresponds to an ACT, whereas smaller lesions correspond to enchondromas. Others have claimed that this is not the case. We find enchondromas that are larger than 5 centimeters. However, we have to put this in mind. Other authors claim that door-to-door or enchondromas that occupy the whole medulla and in contact with both sides of the bone cortices actually are ACTs rather than enchondromas. So these are debatable issues. But the thing that is for sure and not debatable is the presence of industrial scalloping, especially if it constitutes more than 2/3 of the cortex. So this is a sign for a more aggressive enchondroma, or what we call a typical cartilage tumor. If we're in doubt and we can't figure out from the MRI and the clinical examination, then we can do interval studies. We reassure the patient and then see him with a new MRI after 3 months and check if this lesion is increasing in size or not, or if the pain is persistent or not. So if we cannot figure out from the MRI or we cannot differentiate between a latent enchondroma or an active enchondroma or atypical cartilage tumor, then we can do interval studies and check if the lesion is increasing in size or not. So how can we differentiate with an MRI between the active cartilage tumor and the chondrosarcomas? Because active cartilage tumors or active enchondromas are treated by curettage, whereas chondrosarcoma requires wide resection. Actually, the clear-cut signs are cortical breakthrough, obviously if there is a soft tissue expansion, loss of entrapped fat marrow, bone expansion, periosteal thickening, surrounding bone marrow edema or periosteal edema. All these are signs of the presence of a higher grade chondrosarcoma, which will require resection rather than curettage. So let's see some examples. This is an example of an enchondroma of the distal femur. And if you see the MRI, you'll find that the enchondroma has no contact to the cortex. So it's not causing any scalloping. A very benign latent lesion. You can see this on the axial cut as well, with no contact whatsoever to the cortex. So this is a latent enchondroma and could be safely treated conservatively. Whereas this is another lesion of an enchondroma of the distal femur. You can see it on the X-ray. And the MRI shows contact with the cortex. And actually the anterior cortex of the femur is scalloped. You can see here the endosteal scalloping. And with the CT, actually the CT is very useful in detecting this bone scalloping, because you can see here thinning of the anterior cortex by the cartilage tumor. And in the axial cuts of the CT, it's very clearly that the anterior cortex actually is eroded and scalloped from the inside here. And so this makes this lesion not a latent enchondroma, but rather an active enchondroma or a typical cartilage tumor or a low-grade chondrosarcoma. All these three entities will be treated the same with an extended curettage. You can see here the MRI showing the lesion eroding the anterior cortex as well. This is another example of an enchondroma of the proximal humerus. And you can see the MRI shows a long area of contact, more than 5 centimeters long, in contact with the cortex. And you can see here at the lateral cortex of the humerus thinning or endosteal scalloping. The CT as well shows thinning of the lateral cortex. And this was an atypical cartilage tumor pathology and was treated with extended curettage. If you see this example of also calcification in the proximal humerus, which looks like an enchondroma, when we do the MRI, we see that this lesion has a soft tissue extent. It's actually broke through the wall and has a soft tissue extent medially. And this means a soft tissue extent or bone destruction equals a higher grade chondrosarcoma. You can see here, so this is a chondrosarcoma to the chondrosarcoma grade 1-2, and this was treated by wide resection and a modular prosthesis. So you can see with the MRI and imaging studies, we can, to a very large extent, differentiate between groups that require conservative treatment versus groups which require extended curettage versus groups which required wide resection of the tumor. The diagnostic accuracy for differentiating benign from malignant cartilage tumors, as well as benign from low-grade cartilage tumors, were 87% and 77% on the conventional morphologic MRI parameters alone, whereas this percentage increased to 92% and 91% if we combine the MRI with a new tool called texture analysis model. And this was analyzed in a paper by Fritz et al., in which actually, in a nutshell, texture analysis model. We take the MRI picture, transform it, crop a part of it, and see the color and the grayness of the image. And this is put on a histogram to differentiate between the active areas and inactive areas, and then calculated in a percentage to differentiate between the different activity of cartilage tumors. Additional imaging that could help in differentiation were investigated heavily in the literature, but ultimately we found that the bone scan has a very limited value in differentiating the types of enchondromas. PET-CT actually cannot differentiate between enchondromas and ACTs, but it could differentiate between ACTs and chondrosarcomas of a higher grade. However, it has no practical use because actually the differentiation between atypical cartilage tumors or active enchondromas that require extended curettage versus chondrosarcomas could be done fairly easy with the MRI and X-rays. Lesions that has a soft tissue extent or a breakthrough or expansion are obviously chondrosarcomas. You don't need a PET scan to tell you this piece of information. However, in a paper done with a systematic review of the literature in skeletal radiology, actually they found that the PET-CT showed that lesions that has an SUV of more than 2 were more or less chondrosarcomas rather than benign enchondromas. There are other tools like the diffusion weighted image MRI and texture analysis that we have just mentioned. Limited studies are done on these two topics. Maybe the future holds a better value for these imaging studies to differentiate the different types of cartilage tumors. So one would ask, why do we have to go through imaging to differentiate between the types of cartilage tumors? Why don't we just biopsy these lesions and then figure out the grade of these cartilage tumors? Unfortunately, cartilage tumors are very difficult to diagnose their grade and activity just by a core biopsy. Why is that? Because they are heterogeneous tumors, so a core biopsy may not actually accurately reveal the grade. Also, we don't biopsy to differentiate latent enchondroma from active enchondroma because the clinical picture and the radiology will give you a better information than the core biopsy. And we also don't need to biopsy to differentiate active enchondromas from ACT, from low-grade chondrosarcomas, because all these are treated the same. We might need to do a biopsy to differentiate high-grade chondrosarcoma from a lower-grade chondrosarcoma. So biopsy in the lower-grade tumors is not of great value. And moreover, different centers may differ in their interpretation of grade. And we have to know that younger age and locations in the hands or feet are more cellular. So whenever you're sending a pathology specimen to the pathologist, you have to mention the age of the patient and you have to mention where is it coming from, because if you don't mention that this is from the hand and feet, the pathologist may interpret a very cellular tumor as a higher grade of a chondrosarcoma, a higher grade of a cartilage tumor, whereas if you tell him that it's coming from the hand, this high cellularity may be accepted for a more benign lesion. In conclusion, we usually plan the management of cartilage tumors in an MDM setting, multidisciplinary approach with a pathologist and radiologist to figure out the exact nature of the tumor and plan the treatment. Finally, this is an algorithm of how we treat enchondromas at Qasr Al-Aini, at our institution. So if we take it step by step, whenever you have an enchondroma of a long bone, we confirm the diagnosis by X-ray, and then we have to do an MRI. If in the MRI there is no scalloping and the size is less than 2 centimeters with no cortical contact, we reassure the patient and he doesn't need any further follow-up. If there is no scalloping, but it has a size more than 2 centimeters or a cortical contact, we reassure them, but we put him on a follow-up program. After 6 months, he does another MRI, and if it's the same size with no further increase in size, we follow him after a year, and if it's stationary over a period of 2 years, we don't follow him anymore. However, if the MRI showed industrial scalloping, which signifies the presence of a more active enchondroma or atypical cartilage tumor, and we assess the pain and make sure that the pain is due to this lesion and it's not related to a nearby pathology. If it's a painful lesion with industrial scalloping, we do extended curettage for this patient. But if it's a painless lesion, in spite of the industrial scalloping, we do a follow-up MRI after 3 months. If there is persistent pain or there is increase in size or both, then we actually do an extended curettage. But if there is no pain and no change in size, we repeat the follow-up for a longer period of time, for 6 months, then for 1 year, then for 2 years. If at any point there is, again, pain or there is increase in size, we do extended curettage. And if the MRI showed cortical breakthrough, a soft tissue extent, or periosteal thickening expansion, this means that this is a chondrosarcoma. We confirm this by a core biopsy, and if it's a confirmed chondrosarcoma, we go ahead for a wide resection. So this is the algorithm for treating enchondroma of long bones. Enchondroma of hands and feet are a little bit different. They're actually more benign, and the possibility of malignant transformation is very, very remote. So the enchondromas of the hand and feet, if they're discovered accidentally, we follow them up. If they increase in size, then we go for extended curettage. If the enchondroma of the hand and feet are presenting with pain, we do extended curettage. If they present with pathological fracture without previous incidence of pain, then it depends on the fracture. If it's just a crack, we just splint it until it unites, then we do extended curettage. If it's displaced, we don't wait because it's going to heal in a malunited form. So we'd rather fix it and do the extended curettage right away. So this is the algorithm for enchondromas of the hand and feet. I hope this lecture was useful, and I'm happy to answer any questions in your comments following this lecture.
أتمنى أن يكون الفيديو ده كان مفيد ليكم، وفي انتظار تعليقاتكم وأي كومنتس أو استفسارات، وإن شاء الله أقدر أرد عليها في أقرب فرصة ممكنة. وإلى اللقاء في فيديو آخر إن شاء الله يتعلق بأورام العظام.